Assalamualaikum viewers and welcome back to my channel Biotinverse Hub. Today in the playlist of oral and maxillofacial surgery, we will be discussing out another important topic, that is the osteoradionecrosis. In the osteoradionecrosis, we will be covering out definition, the etiopathogenesis, risk factors, clinical features, diagnosis, management and prevention of the osteoradionecrosis. So let us proceed on with that. Osteoradionecrosis, as the name itself indicates, that it is the necrosis of the bone caused due to the radiation given during the radiotherapy. So keeping that concept in mind, let us move on towards the definition, which states that irradiance of the bone lead to the bone necrosis, which means that the radiation of the higher intensities that were given during the radiotherapy, they lead to the bone necrosis. Keep that in mind, that every radiation is not a risk factor for ORN. There will be certain radiation that are of higher intensity, and we will be studying it later on, that the radiation given in the excess of 50 grays, they are basically responsible for causing the ORN. So irradiance of the bone leads to the bone necrosis, which actually means that the bone becomes devitalized. And most important point to be noted out here is that this devitalized bone, it remain exposed through the overlying skin or mucosa that no longer remain intact. And this whole condition, it persists without healing for about 3 months in the absence of tumor recurrence. So this was the whole definition of osteoradionecrosis. You need to remember the following key points out of the definition. First of all, the radiation of high intensity. Secondly, the bone necrosis and the bone become devitalized. Third, it becomes exposed through the overlying skin and mucosa, and this condition persists without healing for 3 months. So let us move on towards the etiopathogenesis. As far as the etiopathogenesis is concerned, there were certain concepts, and one of the prior concepts or old theory about the etiopathogenesis was proposed by the Meyer. According to Meyer, the radiations of higher intensity that were given to the patient during the radiotherapy, and after that any trauma was induced to the patient. For example, let us consider that extraction of the teeth was performed, and quite a traumatic one. So the trauma that was induced further became a site for the infection. Infection spread, thereby causing the condition of osteoradionecrosis. So basically, according to this theory, the whole and sole responsibility was on that infection was caused out there, and that infection was responsible for causing the ORN. So if that was the case, it should be actively responding to the antibiotic therapy, which was not the case. It was not actively responding to the antibiotic therapy, and the condition showed no improvement. So this concept was rejected on this grounds, that if it was the ORN was caused due to the infection, it should actively respond to the antibiotic therapy, which was not the case. After that, another theory was proposed by Marx, and the Marx theory is also known as the 3H principles theory. And in that theory, 3 important events will lead towards the development of osteoradionecrosis. And these 3 important events start from the word H. Number 1 is the hypocellularity, number 2 the hypovascularity, and number 3 is the hypoxia. So these 3 keywords and 3 events, you need to remember them, as they are the one that will be causing the ORN condition. So first of all, let us discuss it in detail. Radiations were given again of a higher intensity in the excess of 50 grays, and what this radiation caused was that bone cells, they started to die because of this direct irradiation damage. And as the bone cell, they become necrosed and the bone cell death occurred, it leads to the hypocellularity. Another consequent event that took in place with that was that the damage to the osteoblast, osteoclast and fibroblast also occurred. And as you know that these are the cells, which is the normal process, that once the cell they are damaged, any kind of damage that occur to them, they are being replaced unreplenished, unrepaired. So as a result, the turnover of the cell, it is maintained. But in this case, the turnover is highly affected and it is not maintained. There is loss of reparative and synthetic functions of these cells, the osteoclast, and fibroblast, which will again directly lead to the hypocellularity. And when hypocellularity occurs, it ultimately results in the tissue breakdown, which we have studied in definition that skin and the mucosa, they no longer remain intact. So this was the hypocellularity case. Now we will move on towards the remaining two H principles. So another important effect will be that vascular damage will also occur due to this radiation injury. We know that the vessels, they have three layers: the inner layer, the middle layer, and the superficial layer. The vascular damage in the form of N-arthritis obliterans in the inner layer of the vessel will occur, and this N-arthritis obliterans, it will ultimately lead to the shortening of the lumen. The lumen becomes thin, and further this condition will be aggravated by the thrombosis of the vessels that will occur. And due to this thrombosis, now the blood supply will be highly affected and it will be blocked, which will lead towards the hypovascularity. As the hypovascularity occurred, we will be seeing that there is no nutrient supply, no oxygen supply, gradual ischemia will occur, and that will lead to the hypoxia. Hypoxia also a condition of increased oxygen demand, but supply is either decreased, not meeting that demand. So hypoxia will also occur. And this hypovascularity and hypoxia will gradually lead towards the development of osteoradionecrosis. So this was whole Mark's theory, depended upon the 3H principle. Number 1, hypocellularity; number 2, hypovascularity; and number 3, hypoxia. Now let us move on towards the risk factors that are following. Number 1, the radiation given to the jaws in the excess of 50 grays, which we have discussed earlier as well, that the radiations of higher intensity are responsible for ORN, or they are associated with the greater risks of causing this ORN condition. Number 2, the ortho voltage given. Number 3, that brachytherapy. Brachytherapy is basically the radiation implantation in the tumor bed. Any advanced tumors of stage 3 or 4, they are associated with a higher risk of causing the ORN. And the recurrent tumors in the floor of mouth, tongue, and retromolar pad area, caries, or any periodontally compromised teeth that are present in the radiation areas that are also associated with a greater risk. Any bony spicules that are left out, they are also associated with a greater risk of causing the ORN. At last, any dentoalveolar surgery performed during the active radiation therapy or immediate post-radiation, which means that if such kind of surgery, that is the dentoalveolar surgery, is to be planned and performed, it should be carried out before the starting of the radiation or radiotherapy. It shouldn't be carried out during the active radiation therapy or immediately after the radiotherapy. So these were some important risk factors. Now we will be discussing out the important clinical features of the osteoradionecrosis. First of all, there will be severe deep boring pain in the irradiated area. Patient may experience the trismus, that is difficulty in mouth opening, or there will be any kind of swelling may be present out there. The soft tissue abscesses will be seen. Another important clinical feature will be the draining sinuses and fistulas will be seen out there, as it is usually the bone necrosis. The most peculiar and specific appearance or clinical feature of ORN will be that evidence of exposed bones. This exposed bone will be seen through the skin and the mucosa, that they will no longer remain intact. Fetid odor, induration and ulceration of the surrounding tissue may be seen, as this is the osteoradionecrosis due to the bone devitalization, bone cell death. So it's very obvious that pathological fractures may be seen. Other clinical features or effect of the radiotherapy may be seen that include the radiation caries on the cervical aspects, mucositis, xerostomia, and fluid lodgement. These were some important clinical presentations of the ORN. Now let us move on towards the diagnosis. While diagnosing this case, we need to be there should be importantly, you should be noting out the history of radiotherapy. Then you should be actively observing the signs and symptoms in the clinical presentation or features of the ORN. After that, we will be moving on towards the radiographic investigations. So you need to keep in mind that in the early stages, there will be no obvious changes seen on the radiographs. But in the later on stages, you can see the sequestrums or the pathological fractures on the radiograph. So radiographic investigation in the form of OPG, CT scan or MRI or CVCTs you can advise to the patient. So this was about the diagnosis. Now, what is the management strategy for the osteoradionecrosis? So we will be covering out the two areas in your management strategies. The first will be focusing on the revascularization of the bone. As there was hypovascularity, the bone has become devitalized. So you should be approaching it through the revascularization of the bone. And the second approach will be excision of the affected or necrotic bone. So the non-surgical therapy will be aiming on the revascularization of the bone, in which we will be giving out the analgesics in form of narcotics or LAs or any other anesthetic nerve blocks. Secondly, we will be giving the antibiotic therapy to the patient. Mainly the penicillin and metronidazoles are prescribed, but in some cases you can also use the clindamycin. And after that, we will go on for the local wound debridement and then packing. Packing it with the neomycin or zinc oxide can be done. And another important management strategy, the non-surgical therapy, will be the low HBO therapy. It is the hyperbaric oxygen therapy that is very much important, and we will be discussing it in the detail in a separate video. After that, the ultrasound therapy, which will be solely aiming on the revascularization of the bone. And all along with all of these, you can give the supportive measure as well, that is the nutrition and the diet of patient should be maintained. So it was all about the non-surgical therapy. Now we will move on towards the surgical therapy that basically aims on the excision of effective or necrotic bone. So in that, you can we either go for the sequestrectomy, or you can directly resect the bone, that is the affected bone. So in the bone resection, you need to go for the two approaches, that is the extra or intraoral approach. But intraoral approach is more preferred. In case you are going on for the intraoral approach, incision it is given along the alveolar crust. After that, reflect the mucoperiosteal flap, and the bone will be exposed. And using a micromotor, you need to drill until the fresh bleed is seen. So this drilling and this fresh bleed will indicate the area of unaffected bone, which you need to keep in mind while demarcating the areas or while placing out the osteotomy cuts for the excision of that bone. After the drilling and perforation procedure is done, these osteotomy cuts are placed and the affected bone it is removed along with the margin of unaffected bone. The remaining bone it is smoothed out and then secure the flap with the sutures. So this was about the intraoral approach. While you are going out for the extraoral approach, you need to keep in mind that incision it is given in the submandibular region, 1 centimeter below and parallel to the lower border of the mandible. Rest of the process it is same. So this was about the management of the osteoradionecrosis. Important point to be noted here is that we should be mostly our aim should be on the prevention of this condition. And while keeping that in the mind, preventive measures, we should be discussing the following, that is the all teeth in the radiation line, they should be extracted before the radiotherapy. Any carious teeth or any periodontally compromised teeth that are present in the radiation line, you should go for the extraction of these teeth before the starting of the radiotherapy. After extraction, primary closure with suture should be done. No sharp edges or spicules should be left out. You should also give the fluoride therapy along with that. A good oral hygiene and diet should be maintained. If after radiotherapy, the extraction carried out, it should be atraumatic. You shouldn't be carried out the traumatic extraction. You should focus on carrying out it atraumatically. And at last, the most important regimen that is given to the patient either before the extraction is we should have to give the pentoxifylline 400 mg BD plus the tocopherol, that is the 1000 unit per day, with or without the chlorudronate. So this regimen, it is based on the concept of radiation induced fibroatropic theory, according to which is that radiation, it will induce the fibrosis and the ORN, and this whole, it is due to the effect of free radicals that are the oxidant. This was the recent etiopathogenesis theory, and on the basis of this regimen was designed. As the pentoxifylline, it is the antioxidant. It basically promotes the blood circulation in the narrow thrombosed vessels. Secondly, it also acts as a vasodilator, and thirdly, it inhibits the fibroblast proliferation and hence act as the antifibrotic agent. The chlorudronate, it is the bisphosphonate, and it is used to reduce the bone resorption. So this is an important regimen you need to keep in mind, and it will be given to the patient before the extraction, and if you are performing that extraction in the irradiated cases. So this was all about the osteoradionecrosis. I hope this video will be helpful for you all. Don't forget to subscribe to my channel and also click on the bell icon so you will get notified about the future videos and updates. Thank you, and Allah Hafiz.